Good morning, folks. I think we're good to get going here. We're just pleased to have Dr. Erin Young presenting to us today, talking about palliative considerations in the management of end-stage renal disease. Fascinating topic. It's been bubbling up in the industry for probably about the last decade that people have been talking more seriously about this. And so we thought we really needed to get down and deep on this. So Erin, thanks for being here, and turn the floor over to you.
Thank you. For those of you who don't know me, I'm Erin Young. I completed the fellowship here locally with Trinity a couple of years ago and have spent my time since with Faith Hospice and Trillium Palliative Services. I am by no means an expert in this field of end-stage renal disease, but it definitely is something that I feel very passionate about. And like Dr. Mulder said, it's an evolving area within palliative medicine and a lot of room for growth and improved care. Don't have any disclosures to share with you all today. If all goes as planned, by the end of this presentation, you will feel comfortable in your ability to evaluate and manage symptoms associated with end-stage renal disease, understand prognostic factors associated with end-stage renal disease, be able to navigate those sometimes tricky and emotional goals of care conversations, including discussion about dialysis in particular, and be able to understand medication management in the setting of dialysis. So I thought that, what do they say? A picture's worth 1,000 words. And this is just showing the trend in prevalence of end-stage renal disease over more recent years. And when I looked at the literature to try to see why is there more end-stage renal disease, wondering if are we just diagnosing more, or are people living longer? And it really seems like consistently the aging baby boomers are, I don't want to say to blame, but the reason why we are seeing more and more end-stage renal disease. It's just a matter of population that's aging now. Wonderful librarian over at Trinity pulled probably on my end an embarrassing amount of articles for me to look at in preparation for this. And I'm a little bit ashamed to say that this one article is really what I used as the foundation for this presentation. And I'll cover it pretty thoroughly, but if you're gonna pull up one article to have on hand as a reference tool, this would be it. So the 10 tips nephrologists wish palliative knew. And I will say, a little sneak peek, some of these tips, I think we could say palliative wished nephrologists knew.
That's the follow-up part.
Yes, exactly.
10 tips series is so good.
Yeah, it's really helpful. So, but they stole our thunder a couple of times here. So we'll jump right in. Tip number 1, care for patients with CKD and end-stage renal disease benefit from multidisciplinary input from nephrology, primary care, and palliative. They're very specific about these 3. And I thought this was interesting that from a nephrologist standpoint, these were the 3 specialties that they felt like were essential to care of those with chronic kidney disease. I think the main reason for that is, and we'll see this throughout the presentation, but it's pretty rare for end-stage renal disease to stand alone. It is oftentimes, and I would venture to say almost always associated with things like cerebrovascular disease, heart disease, diabetes, and even malignancy. And so there's a bunch of different numbers out there, but generally consistent with saying about a third of patients with, at a minimum, with end-stage renal disease have 4 or more comorbid conditions. So 4 is pretty impressive, and I think of that as involving probably 4 major organ systems. Nephrologists in this article and through most of the articles that I ended up looking at are very humble in saying that they really do not feel prepared or lack training in providing these palliative care or fulfilling those palliative care needs for their patients with end-stage renal disease. And they also talk about how the dialysis center becomes the medical home, and patients are spending so much time there that often primary care, for example, drops off as they don't have time for other appointments and other tests to be done. And so nephrologists are kind of waving the white flag saying, we need help. So hoping to involve primary care and palliative more in that way. Tip number 2, they tell us that serum creatinine and estimating equations are used to provide approximate values of glomerular filtration rate. We kind of have this, I don't want to say joke, but kind of little funny thing we say around here that nephrologists, the moment you're born, they put you in stage 1 kidney disease. And so when you look at the literature, there's kind of this debate about GFR, and is a decrease in GFR as we age pathologic, or should that be considered normal aging? But regardless, we know that a reduction in GFR, whatever it is, small or large, has been consistently associated with decreased physical function, increased frailty, and reduced cognitive function. So all 3 of those things are associated with any reduction in GFR, I believe starting at like a stage 3 chronic kidney disease level, which is when we start to see that GFR reduced. And there are just oodles of different ways for assessing and calculating GFR, but the most popular, because it's the most validated, is the estimated GFR, or eGFR. And when you're looking at a BMP done locally or across the country, that eGFR is what our laboratories are using. And they're using the CKD epi creatinine equation pretty consistently. So that's what you'll see being used. And if you are really just all in on this, you can calculate that yourself, put in a couple of the factors used, and MD-Calc will pop out that result for you. Now, if you are like me, I started just digging myself into a rabbit hole here, thinking, okay, so GFR, that's great, but I've always used creatinine clearance when I'm looking at medication dosing in those with chronic kidney disease. So which one am I using, and when and where and why? GFR is used for the staging and assessment of chronic kidney disease, and that's that CKD epi equation that we just talked about. But creatinine clearance is what is used for drug dosing. And I think most of us, if we're gonna look at creatinine clearance, are using this Cockcroft-Gault equation. It's interesting because across the literature, that's what's used in the pharmacy world. That's the equation that's used for creatinine clearance. But the National Kidney Foundation, who's kind of the gatekeeper at making recommendations for this, said they don't recommend it for clinical use and it should be used for research only.
Interesting.
Yeah. I typically use, again, this MD Calc calculator, and it's pretty easy. I have it bookmarked on my laptop. And so the data that you need for that, the entry points are pretty easy to find, right? Just basic weight, their last creatinine level, age, sex. And so I found it pretty easy to use. It is particularly important to use in situations where we have elderly patients, 75 years or older. It's helpful in the extremes of muscle mass compared to the eGFR. So folks who are particularly underweight or overweight, and then patients taking medications that are largely renally excreted or have a narrow therapeutic index. Okay, I had this pun that I was going to use at the beginning of the presentation and I forgot to, so we're gonna double up here. What I was gonna say was this is a rather dry topic. Yeah. So I'm gonna include some jokes here. What do nephrologists say to non-compliant, which I know we don't love that term, but bear with me, non-compliant patients? Buddy? You're in trouble.
There you go. Your kids are the dad joke age, aren't they?
Yes, they are. Yeah, can you tell? All right. Tip number 3. Patients with advanced CKD and end-stage renal disease have symptom burdens as high as patients with advanced cancer. I knew this. I see this. This is why I feel passionately about palliative care and end-stage renal disease. But I still included this little photo of Bunsen, and I think this is either Bunsen or Beaker, but nonetheless, because it still kind of like took me back. I think that's a really still shocking statement. So greater than 50% of dialysis patients experience pain, fatigue, and pruritus. More than a third of chronic kidney disease patients experience one or more of dry skin, dry mouth, sadness, sleep disturbance, irritability, sexual dysfunction, and cramping. And that's all CKD comers, not just end stage. So that's a pretty profound, to me, collection of symptoms associated with this chronic disease. And alongside that, over the general population, there's a substantially higher prevalence of depression in chronic kidney disease. Again, kind of hitting home the point, not just end-stage renal, but all comers with chronic kidney disease. And those with CKD and depression, of course, have a decreased quality of life. But also, I thought this was really fascinating too, have increased likelihood of progression to end-stage renal disease. So just having that comorbid depression and chronic kidney disease increases one's likelihood of progression to end-stage renal. Just really, really heavy. And also they have increased rates of hospitalization and all-cause mortality. The evidence shows symptom management when they ask folks with chronic kidney disease, symptom management is a top priority for patients. And the literature shows too that nephrologists tend to underestimate symptom prevalence. And I think that's a little bit unfair. It's probably not just nephrologists. It's probably primary care. It's probably palliative too. So all of us, in the medical system, I think we're really good at, managing numbers and prevention and, maybe working to modify that trajectory a little bit. And, that takes a lot of time, and managing symptoms isn't always a top priority on our end.
One of the things I wonder when I hear that type of story is, of course, the question is why would we underestimate? I mean,
Yeah.
especially as palliative practitioners underestimate, but I sort of see a similar parallel. I've seen this certainly in oncology, where there is an expectation that because of the disease progress, there is going to be some burden of symptomatology that comes along with it. It's just part of the deal. You have pancreatic cancer, you're going to have pain, you're going to have nausea. So it's not that we accept that but it's just that it's just part of the gig.
Yeah.
So, on one far end, kind of snap out of it. This is your life now. But I think the other thing is that with renal disease in particular, they tend to be less focal. They tend to be a little bit more constitutional.
Mhm.
And we don't necessarily do as well with constitutional symptomatology as we do with this hurts here.
Yes.
Yes. And so I think that so this is extraordinarily important, I think.
Yeah, I agree with you. I think both realizing the symptom burden was eye-opening for me, but also thinking just along the lines of what you said, right? Someone comes into the cancer center, we're seeing them for a palliative consult. It is much easier in a lot of ways to say, oh, you've got bone metastases, we're going to manage that pain. Of course, it's just more straightforward versus someone not complaining, but mentioning fatigue or dyspnea. Those things are much more difficult to manage and address. This is another visual that I think is just really worth reflecting on. And again, this is looking at not just end-stage renal, but all those with chronic kidney disease compared to all those without. And this came from the CDC kidney surveillance system, and looking at similar age groups and similar other comorbidities. So individuals with chronic kidney disease, you can see just in function have a much higher burden than those without. We'll look at a couple of symptoms here associated with end-stage renal, and hopefully I'll give you some new tips. When it's associated with kidney disease, itching is a metabolic source. That being said, dry skin definitely can exacerbate the symptom of itching in kidney disease. And so it's really prudent to address that dry skin. I really have seen benefit in everybody with the soak and seal method, where you have your shower or bath and those pores are nice and open. And so you seal in that moisturizer with an emollient and then use your moisturizers. Another tip that I often give people is that the lotions or things that come in like a pump bottle or even like oftentimes a squeeze tube, they actually have more water in them and even alcohol sometimes, which seems kind of, why would they do that? So they're not as moisturizing and it can be more irritating than things that come in, for example, like a jar. And the old wives' tale of oatmeal baths, there's a reason why Aveeno markets that because it actually works. So that's another way to both provide moisture and help with some of the irritation that comes with dry skin. There's also a good evidence to show that using cooling agents can provide a sensation that alleviates itching, particularly in end-stage renal. So your calamine or products with menthol in it can be helpful. Topical lidocaine, this article was really specific in pointing out not because of the numbing effect, but because of the kind of cooling effect that comes with the lidocaine. And then, of course, a cold washcloth can help too. I did not know this, that Zofran can provide some significant relief with itching in end-stage renal disease or kidney disease associated itching. So that's a good one to keep in our back pocket. It's easy to access. And so I know I'm gonna think of that one more often. And then specifically antidepressants of sertraline, amitriptyline, and doxepin have really good evidence to support their use in managing, especially long-term itching in patients with end-stage renal disease. And this was another kind of surprise to me. I had thought there was good evidence to support gabapentin and Lyrica in this situation for symptom alleviation, and they weren't really willing to go out and say. They just said potentially helpful. There's not good data to support that now.
The other thing that there's not good data, but anecdotally we found helpful when we've gone through the list is ketamine.
Oh, yeah.
Oral ketamine, yeah, or
that's
systemic ketamine.
Okay.
Because of the NMDA blockade, it works really, really well for this.
That's a good thing. Okay, specifically oral.
Yeah, I'm trying to find that in the literature.
Okay, right.
Would your antihistamines be ineffective because of the source of the symptoms being metabolic versus?
Primarily.
Okay, so like things like your
It'll
visceral probably wouldn't be helpful.
It's sedating, it'll take a job, but
Can't be a 2 if you're asleep, right?
Pain and I'll jump right ahead. I mean, it wouldn't be a palliative lecture without mentioning ketamine, right?
of course not.
So,
Oh, there you go.
yeah, definitely for pain management and end-stage renal disease, always consider ketamine. Ketamine for everything. This is great because I'm coming off Dr. Andrus's recent ketamine lecture. So, think of topical agents. So topical NSAIDs are safe and effective, especially when the pain source is musculoskeletal in nature. Lidocaine is always a good option, and topical morphine. The study that I was looking at specifically recommended a gel, and they gave the advice of asking for prescribing the morphine sulfate 10 milligrams and 8 grams of sterile gel up to 3 times a day. But I know that we call our local compounding pharmacist and describe the situation to them and what we're hoping to do. And 9 times out of 10, in fact, probably 10 out of 10, they give me a better idea than what I had. So I would encourage you all to reach out to our compounding pharmacist if you're considering something topical. Of course, Tylenol is safe in kidney disease. The best opioids to use are methadone, fentanyl, and buprenorphine. Those are all long-acting agents, and oftentimes we do need something more immediate release. And so hydromorphone is what's commonly used or recommended. However, we have to be just mindful of the metabolite of hydromorphone, which has a neuroexcitatory effect, but that shouldn't limit our use of it. I also will say that I've seen oxycodone used pretty well and well tolerated in situations of chronic kidney disease and end-stage renal disease too.
Yeah, and I appreciate you mentioning it, because it's not that we can't use those phenanthrine opioids. You just have to typically dose them a little lower and longer.
Yeah.
Just monitor for side effects and
Exactly.
because there are still pockets where they say, well, you can't use them.
Yeah,
But you can. You just need to
Yeah.
monitor closely.
exactly. Fatigue. I think with all things, but not just chronic kidney disease, but perhaps especially chronic kidney disease and stage renal. It's multiple factors. It's not just any one thing. So making sure when someone's mentioning fatigue or lack of motivation, that we're addressing depression, poor nutrition, sleep disorders. There's really good evidence to show how managing anemia and treating anemia in end-stage renal disease really improves fatigue significantly in this population. So blood transfusions, if they meet those requirements, improve both fatigue and self-reported well-being. And of course, the erythropoietin stimulating agents improve fatigue, and also the scores for quality of life improve when those treatments are used. I know in our cancer population, there's really good evidence to support use of psychostimulants, but in end-stage renal disease, chronic kidney disease, there's no evidence to support their use, and in fact, maybe more risk than even potential benefit with the side effect profile suppressing appetite, and then the negative cardiovascular effects that can be associated with those stimulants, especially when we're looking at this population who, as we said, have 4 or more comorbid conditions. Probably cardiovascular condition is likely to be alongside the kidney disease. Fluid overload status. I think for me, this is a tricky one that admittedly I try to stay out of in the palliative world, not so much in the hospice side of things, because I don't want to get between cardiology and nephrology. But I often will pick up the phone and call particularly the cardiologist, and inquire and say, hey, this is what I'm thinking, or do you want to give the patient a call and give your recommendations? But of course, when we think of fluid overload status, our goal is to manage the associated dyspnea without contributing to more cramping or debility. And it's a finesse of minimizing the electrolyte abnormalities too. So there's 2 ways to approach that. If they have a longer survival expected, you want to be a little bit more careful, but also do something that's not gonna make too much more work for them. And so the nephron blockage was recommended with a thiazide plus an aldosterone antagonist, so your metolazone and spironolactone. And that is a more occasional lab monitoring requirement. But if someone has a shorter life expectancy, like in hospice care, being more aggressive is more acceptable. We don't worry so much about what those labs are doing, and more looking at getting them comfortable quickly. And so using something like a loop diuretic, furosemide, would be a more appropriate approach in this population. If you've got someone in particular in the hospital with an urgent situation, and again, you're going to have a whole team that you're collaborating with of specialties here, but sub-Q or IV furosemide is the recommended course. You're going to get a quick onset of action within 30 minutes. And if you're looking at doing the dosing, usually they say take the oral dose and divide that by half. And something just to keep in mind, that those more end-stage patients are going to often require very high, maybe even seeming to us absurdly high doses in order to achieve the diuresis. We've got to get a little extra squeeze out of those kidneys. Other things to consider, and I think this actually comes up as one of their points, so I won't belabor it now, but just other things to keep in mind when we're looking at symptom management, especially if someone's hospice minded. Those ACE and ARBs, which really probably served them well for a time, as far as delaying progression. There comes a point where they can, like all things, start to perhaps be more harmful than helpful, especially when someone's already in the end stages. So consider looking at signs of hypotension, which we know can contribute to falls and dizziness. And just keep in mind that tight blood pressure control is really a long-term benefit, and a little bit of a wider range in the end stages is less harmful. Tip number 4, differentiating between CKD and acute kidney injury is important. In the elderly, CKD often progresses slowly, while acute kidney injury is a bad prognostic marker for all patients, regardless of age. And I think that's something worth keeping in mind, especially in inpatient palliative care rounding service. When you're having these goals of care conversations, talking to people about what to expect, there's a big difference between if someone's got chronic kidney disease, even stage 4, versus they've had an acute kidney injury. Both of them have increased mortality risk, but definitely different trajectories, which can make prognostication easier in some ways, but more difficult in others. So clinical course, especially in the elderly, is incompletely described by large studies, right? So there's nothing consistent. We don't have a lot to stand on when we are talking with our patients about this. But we do know that outcomes, progression, death can be influenced by age and other comorbidities, and advanced stages of CKD are associated with a higher risk of progression to end-stage renal disease across all groups. Estimating that clinical trajectory for the elderly patients with chronic kidney disease requires weighing the overall risk of death from any cause against likelihood of renal disease progression. So the Veterans Affairs study has a lot of really good data regarding a lot of things, but especially in the kidney world. And so they divided patients into 2 groups, 85 and older and 65 to 84. And in that older group, the risk of all-cause mortality eclipsed the risk of progression to end-stage renal disease, regardless of where their GFR was at. So essentially, end-stage renal disease didn't increase their risk of death. Their age really did. And in the patients between 65 and 84, with a GFR less than 15, then the risk of progression to end-stage renal outstripped that risk of death. You know, in palliative care, we really love, or maybe it's just me, we really love a good trajectory prognostication graph. And so this is one just kind of, I think, helpful when we're having these conversations with folks with acute kidney injury. It could go one of a lot of ways, right? Of course, there's that chance of full recovery if they have acute kidney injury in the setting of chronic kidney disease. That's going to be a little bit of recovery, but then a more steady decline. And then, of course, the option is acute kidney injury with a more rapid progression to end-stage renal disease. And again, I think taking a step back, which we're all really good at when having these goals of care conversations, but that just big picture. So considering their prior creatinine trends, right, can be a big player in how this goes when they've sustained a kidney insult. More on prognostication. So in general, there's kind of a consensus. If someone has end-stage renal disease and they are electing conservative management, meaning non-dialysis. They have an estimated, so it's still a wide range, but I would say it's still within months, 6 to 23 months of life. Someone who is on dialysis, they have a life expectancy of 5 to 10 years. Again, a bit of a gap, but you could say years. With a median life expectancy, if they elect to stop dialysis, of 7 days.
And when you use ESRD on that, remind me again what the threshold is on that?
For end-stage renal
Yeah.
disease, less than, they would say stage 5, so less than
Stage 5.
15.
Okay,
Yeah,
thank you.
yeah,
I suspect that one.
yeah, yeah. And then hospice eligibility is something that we're always thinking about and wanting to talk about. And so it's variable. And I always think if someone's a candidate for hospice, they're hospice minded, their GFR is 15 or less, we can make a good case for hospice admission, but it helps if you have things like uncontrolled metabolic derangements, uremic symptoms causing frailty or encephalopathy, a critical volume overload causing respiratory issues or nephrogenic ascites, and then the presence of calciphylaxis. Okay, this isn't specific to end-stage renal disease, but I couldn't pass it by. A kidney stone walks into a bar. The bartender says, "What'll you have?" And the kidney stone says, "No, thanks. I'm just passing through."
There you go.
All right, tip 5. Since patients with kidney disease have variable illness trajectories, shared decision-making and advanced care planning are essential to help patients decide whether dialysis or conservative management will help meet their goals. So this is what I mean. I think we could be telling the nephrologist and the rest of the medical community this. And I put my soapbox there because this is one I stand on often. So those with chronic kidney disease, not just end-stage renal, are at risk for sudden functional loss or death due to comorbid conditions. I feel very strongly that folks with especially stage 4 or even especially 5, they should really have a palliative consult because they are at risk for this sudden change. And I think it's easier on all of us to have these conversations upstream rather than in a moment of crisis when this sudden loss has happened. And I thought this was interesting, and we see this in the cancer literature too, right? A large percentage of patients on dialysis do not recall a conversation about alternatives to dialysis. And so that's where I believe palliative can be intentional about having those conversations with them, separate from all the other discussion that's had regarding starting dialysis. Tip 5, many nephrology providers feel unprepared to discuss prognosis, end-of-life care, and non-dialysis management options with their patients. So that lack of training, that prognostic uncertainty that we've talked about, to me, really results in the perfect storm. And so patients with kidney disease have a lower prevalence of advanced directives compared to patients with other serious illnesses like dementia and cancer. It's really, it's a lot and surprising too. Dialysis patients are more likely to be hospitalized and less likely to receive hospice care at the end of life compared to patients with cancer, despite having a similar symptom burden like we talked about. And I was reflecting on my own hospice population, and I have very few patients who transition from dialysis to hospice care. More we see the patients who elect to forego dialysis and then sign on to hospice. So I think, of course, it's important to be able to meet with these patients before they start dialysis and have those discussions, but just as important once they've initiated dialysis to have those conversations and keep talking about their goals and quality of life. I found that I did not truly understand the options when it came to dialysis before fellowship in particular. And I'm still learning, but I think it's important to know what the nephrologists might be offering or the conversations they might be having in order for us to talk through those options. And so I just want to give you hopefully a little background information, and hopefully it's not too simple for you all. Hopefully you learn from this too. So there are three main types of access for hemodialysis, and you might hear your patients talking about these different options and what's being offered to them. So there's a fistula, which directly connects artery to vein, and that is what's considered to be the safest option. It can last for years. It's least likely of all of these options to become infected or to develop thrombus. But it's best to have this procedure done 2 to 3 months prior to the expected initiation of hemodialysis. So I'll often see in nephrologist notes that they're putting in a referral for this months in advance of anticipating someone might progress to be needing hemodialysis. Another option is a graft, and that uses graft material to connect the artery and vein, and that's considered to be the second best. It's more prone to infection and thrombus than the fistula, but a benefit to this is that it really can be done just 2 weeks prior to expected initiation. So think of this in somebody who maybe has a more rapid acceleration and is needing dialysis a little bit more urgently. And then there's what we tend to see in like a hospital setting with a catheter placed directly into the vein. It can be placed same day. Dialysis can be started as soon as that's done, essentially. Really is only a bridge for short-term use. And it's important to note that a tunneled catheter is safer than a venous catheter and can be used for longer periods. There are only 2 absolute contraindications to dialysis: no possible vascular access and cardiovascular instability. So severe. Someone who's in the ICU and maybe not responding to treatment stability there for cardiovascular disease. A couple relative contraindications, so just things to consider would be malignancy, except of course in the case of multiple myeloma, Alzheimer's disease, advanced liver disease, and then those hypotension unresponsive pressures. Indications, everyone else. Peritoneal dialysis, I thought there was just one type, but there's 3. So continuous ambulatory peritoneal dialysis, that's done manually, and it's several times per day. There's continuous cyclic peritoneal dialysis, and that's done automatically by a machine overnight, and can be done in the home. And then intermittent peritoneal dialysis is done at home or a healthcare facility. And it's like the continuous ambulatory dialysis, but it's more intermittent. A lot of benefits to this. There's more independence and time for daily routines. You have a less restricted diet compared to hemodialysis. There's good studies to show longer lasting kidney function, actually. So that kidney function might hold longer compared to hemodialysis. And I'm not really sure why. I didn't see a good reason for that. People who have fear of needles, it might be something worth considering. And the side effects tend to be less severe, the cramping and lightheadedness compared to hemodialysis. There's a couple of contraindications to consider when talking about this. So if they've had a lot of abdominal surgeries, there's likely scarring that would prevent this from being helpful for them. If they've got a large hernia, if they have poor, this one's huge, poor social or caregiver support, it's really intensive, not on the medical community, but on these individuals. And if they have some sort of gastrointestinal disease like inflammatory bowel even or diverticulitis, they're not a candidate. There are some years or some risks, although it can tend to slow progression of the GFR loss, it does seem to be less efficient or effective and can result in hernias. Also is definitely known to be associated with weight gain and hyperglycemia because of how it works. And infections are much more common, specifically peritonitis. And since I've been talking for a long time, I'm going to actually skip over CRRT. And of course, it's always important to keep in mind those alternatives to dialysis because patients want to know what conservative management looks like. And as the nephrologist pointed out, and we've said, you know, having us at the table, primary care at the table who've known these people for a long time and their nephrologists together collectively can offer a good plan for them. Multiple studies have shown that conservative management does not result in immediate death. I think that's the fear of a lot of people and their loved ones, that if they don't get dialysis, they're going to die immediately. And that's just really not true at all. Oftentimes people, even at the end stages, survive for 12 months or more. All right, tip 6. Dialysis initiation inconsistently modifies symptoms experienced by patients with kidney disease and may not always prolong survival. So I think a lot of people think they're going to feel better with dialysis, and really that is just not true. Initiation of dialysis often improves specific symptom or issue that resulted in the need. So for example, uremia can cause severe anorexia or nausea. And with initiation of dialysis, that does improve. And those symptoms associated with electrolyte abnormalities, those do improve initially. But as time goes on, that symptom burden isn't any different compared to those who seek conservative management. And then although there's limited data, patients with other life-limiting illnesses may not have prolonged survival with dialysis initiation. So something to consider as well. I jumped ahead. This is an evolving clinical risk prediction tool for 6-month mortality after dialysis initiation among older adults. So it looked at a number of predictors and is well supported in the nephrology world, but it's still pending that external validation. So for those of you who can't see this, imagine cutting a tomato in half and then taking a cross section of this. And now I will never be able to look at a tomato and not see this.
That's a little freaky.
Isn't it?
Yeah.
Yeah. Tip 7, patients with end-stage renal disease have complex pathophysiologic mechanisms that can be thought of as a confluence of cardiovascular disease, chronic inflammation, and bone disease that collectively drive malnutrition and medical frailty. Whew, that's a lot in one tip. So I thought I would just touch hopefully briefly on frailty here, and just to say age or disease-associated loss of physiologic reserve, so characterized by reduced strength, endurance, and poor physical function. Not surprisingly, as kidney disease progresses, the prevalence of frailty increases. And so this is up to 30% of hemodialysis patients meet the criteria for being considered frail. Honestly, I thought it would be more than that. Of course, increased frailty is associated with increased hospitalizations, morbidity, mortality, and has a wide variable illness trajectory like everything else we've talked about today. If you're trying to predict who might be at risk for frailty, age, comorbid burden, chronic inflammation is a big marker or predictor of frailty. But there are reversible factors such as poor nutrition status, fluid overload, metabolic derangement, and acute illness in this patient population with end-stage renal disease. All right. Again, look at this. This is one of our favorite trajectory images here. And I thought this one was just really fascinating because they have added this line of CKD, no dialysis. So you have our kind of usual, what we see, cancer curve here. We've got our chronic disease curve or line here, which will say end-stage renal disease on dialysis would follow this curve. Our frailty of all causes and dementia tends to look like this, but our CKD conservative management, CKD stage 5 conservative management really follows a line similar to cancer, where you have this stability over time and then a more rapid decline at the end of life. Patients on tip 8, patients on hemodialysis have high mortality, and there are validated prognostic tools that can help predict mortality survival in end-stage renal disease population. So we will look at just a couple of those. This Charlson Comorbidity Index, that doesn't just look at end-stage renal disease and dialysis, but looks at all cause predictors. So what other comorbidity conditions do they have? And again, MD Calc has that for us. And this is what the nephrologists are recommending we use. This can be found on this Calculate by QXMD website. There's a predictor 3-year survival for elderly end-stage renal disease patients. There's a 3-month mortality incident elderly end-stage renal disease patients. This is a mouthful. And then a 6-month mortality calculator for hemodialysis. Okay, we're getting there. Tip 9. Although indicated for multiple chronic conditions, the use of agents that inhibit the renin-angiotensin-aldosterone system need to be individualized for frail, elderly, and dying patients. So I touched a little bit on this earlier. The renoprotective piece of that is they work by decreasing the intraglomerular pressure, decreasing GFR. You can see an increase in serum creatinine at the start of therapy, but landmark studies showing benefits did not include the very frail with limited prognosis. So again, just taking a step back, looking at where we've been, where we're going, what their goals are, and deciding if this medication, often in someone who has a high pill burden, is something that's meeting their goals. Tip 10, patients with end-stage renal disease underutilize hospice compared to those with other serious illnesses. Nephrologists say, and there's some truth to this, because hospice regulations make it difficult to utilize hospice services while continuing hemodialysis unless another distinct terminal diagnosis is present. We'll talk about that piece in just a minute. So 46% of Medicare patients in 2015 utilized their hospice benefit overall, but only 25% of Medicare beneficiaries with end-stage renal disease received hospice care at the time of death. So pretty significant difference there.
There's an opportunity there.
Yes, there's a huge opportunity there. Should have put a picture of my soapbox on that slide too. Compared to cancer and heart failure, final month of life, people with end-stage renal disease have more hospitalization, more utilization of intensive care units, higher rates of cardiopulmonary resuscitation and mechanical ventilation, and are just more likely to die in a hospital. So they mentioned some of this blame to be put on hospice requirements. And part of that is that hospice is required to cover all reasonable and necessary care related to the terminal diagnosis. So the key is related and contributing to prognosis. So although someone might have, let's say polycystic kidney disease on dialysis, but they have cancer, which is listed as their terminal diagnosis, one could argue that cessation of hemodialysis would change their overall trajectory, and therefore it's something the hospice should cover. Now, this is important because Medicare spends over $83,000 per year per hemodialysis dependent patient. So that's a huge financial risk for a hospice when they're admitting a patient with end-stage renal disease who desires to continue hemodialysis.
Can we just,
Yeah,
one note
yeah.
relative to the hospice thing? Since you used the term a handful of times, I just wanted to come back to the all-cause mortality.
Yeah,
Because these folks, as you pointed out, tend to be frail, nothing in the body really works all that well when you have ESRD. Forget the dialysis.
yeah,
And I think that when we are, as hospice physicians, looking at, is this person eligible or not? That's a huge, important comorbidity, even if it's CKD3,
yes.
CKD4, maybe it's having an impact on that, but it is impacting their system. They die quicker
Yes.
and sooner. And so don't ever forget that. And you can use that in your calculus in terms of looking at hospice eligibility. And I think that's an important factor that we sometimes overlook. We sometimes get caught in the weeds with our dementia patients and our CHF patients, our COPD patients. And, they're on the cusp. But if they've got that CKD, that's a very, very important indicator that can move them into a hospice eligible
Yes.
category.
Yes.
And if they're not on dialysis and doesn't carry the burden that you just outlined.
Yeah, I'm guilty of that. I often, when I'm writing CTI narratives, I often will not include CKD, especially stage 3, in that note, painting that picture. And it definitely should be. It does change that.
I think it does.
Yep. Just briefly, I have 2 slides on methadone because I think it's really important, and I myself have had a lot of questions on this in the setting of kidney disease and dialysis. So it's important to note that concentrations of methadone are not significantly altered in renal impairment. That's why we saw it back on that slide as a good option for pain management in end-stage renal. Of course, considering all the usual things before starting methadone in this patient population and all patient populations. There's really never a dose adjustment needed for kidney disease. But really, as we move up in our stages of chronic kidney disease to 4 and 5, we just have to be more cautious with, especially initiation, those initial doses, as well as how quickly we titrate those. And then in regards to hemodialysis, it's not significantly removed by 3 times weekly intermittent hemodialysis. Only 2 to 15% is removed during that process. So they do say, though, if you're initially starting someone out on methadone who's on dialysis, maybe consider a dose reduction and titrate gradually, no different than someone not on dialysis. But you don't need to supplement that dose post hemodialysis. So just dose as you usually would. Oh, is there a question?
You keep going.
Okay. And then the same is true for peritoneal dialysis. We made it.
Well done. Excellent.
Questions?
So, why don't you go ahead and stop screen sharing there, and then we'll open it up for questions for the red. Questions for Erin.
You know, when else I've noticed too that there's so many people in hemodialysis and not many people on peritoneal dialysis. In your readings, have you found why it's so favored to do hemodialysis?
Yeah, I think it's a number of factors, but I think, you know, when you look at those contraindications to peritoneal dialysis, there's a lot of people who fall into that category, whether it be someone who's had multiple abdominal surgeries or has a presence of even a small umbilical hernia as a contraindication. So I think it's easy to say they're not a candidate for it.
Other questions? This is gonna.
Aaron. Oh,
Oh,
No, go
sorry,
ahead, Ken.
John. Ken Hansen, quick question. In my ER practice, I kept seeing people that were recommended for hemodialysis. They still had renal function. Maybe their CKD, that was 20 or something, but they were trying to get ahead of, getting the graft in and all that. So they had the temporary catheter placed. They came in septic, went upstairs and died. And I would sit there and think, well, what if we had just done conservative management? How long would that patient lived? And I'm sure no conversation was ever had with the patient. Now I know that's a small risk factor, but still, I kind of scratch my head sometimes thinking, would we have changed the trajectory of that patient's life if we had said, hey, maybe conservative management might be a way to go? So I'm just curious on your thoughts.
Yeah, I think that's really compatible with what I saw in the literature too, that that conservative management has optimizing that really has a pretty extended prognosis, in my opinion. So, and it fits with what I saw too, that these conversations aren't had with people about the option for conservative management. So I think you're right. There's definitely room for improvement in that regard.
Right, other comments, questions?
Just think about the slide you had that talked about, again, kind of what other alternatives were discussed with patients before starting hemodialysis. The amount of regret that patients have after initiating it kind of just makes me think of like, all right, we've got on the roller coaster and now we're on it. I feel like there's not another option after you've already initiated such an invasive and intense kind of intervention.
Yeah, I agree with you. And I think that's where the piece is missing about even after someone started dialysis, making sure palliative's on board to continue those conversations. Reminds me a bit of like a feeding tube in someone who maybe has ALS or Parkinson's, right? Like once they start, then it's gonna be really challenging to decide when to stop.
Right.
And dialysis is definitely along those lines.
It is an interesting conundrum because, there's so many places in medicine when we talk about interventions, and the expectation that we set up, through the work that we do is that nothing's forever. There are always opportunities and options to reconsider what we want to do in terms of continuing or discontinuing. And yet somehow the patients feel once they're in, they don't have that flexibility. And I wonder where that comes from.
I don't know. Is it an external pressure or a fear? I don't know. All of those things. Yeah.
Question popped up here is, are there any studies that look at cultural variations with the choice to dialyze?
I'm sure there are. I did not look at those though.
Okay.
Yeah.
Yeah.
That would be interesting to see.
Yeah, there's a lot of meat in here that probably is fodder for yet a kidney disease part 2. So
Yeah.
be thinking about that because we'll probably tap you again on this.
I mean, across multiple different kinds of demographics, like access, how far is your closest dialysis center versus, like you said, social support and being able to do peritoneal dialysis versus across socioeconomic and race and culture, yeah,
So social
I'm
determinants
sure-
of health.
I'm sure there's
The other thing that
variability.
yeah, and we did talk about, but I think it's worthwhile just, you know, the Medicare coverage for dialysis is complete and it's across the board for everybody in terms of that. If you meet the criteria, Medicare will cover that, which is one of the first that came about somewhere in the 1960s, actually. And so that's where it just became, if you have end-stage renal disease, you need dialysis, the government will pay for it. And so that really opened the door for anybody who needs it can get it. And it's an open-ended thing. And so when we talk about the paradigm of not wanting to give up or not needing to give up, or there's a huge incentive within the medical field just to keep it going.
Yeah.
And so that somehow influences that whole process. I mean, even, a lot of people say, well, that was kind of like well, hospice Medicare benefit came in the early 80s and was sort of in a very limited way patterned after what the government did to say, hey, if you've got this condition, we're going to pay for it. If you are hospice eligible, we're going to pay for it. And so that created this it's really normalized.